This conference will now be recorded.
Okay, so thank you for starting the recording. And this is Connie Davis from CCMI, and we are very fortunate to have with us today Kristy Baxter. And Kristy is going to tell you about a very interesting research project that she undertook. And I will actually let her introduce herself and just take off in just a minute. But I do want to make sure everybody knows how to use the Gotomeeting control panel. The most important thing to pay attention to actually is your audio system. If you look at the little control panel there that you should see on your computer, there's a bar that says audio. And if you open that, you can actually look at your connection there, and you can see what your status is. So if you aren't muted, we'll ask you to go ahead and mute yourself so that there's not any interruption during the presentation. You're welcome to ask questions. You can also use the chat to do that. So if folks want to chat in where you're from, we'd like to see what our representation is. I see several folks across Canada for sure. We have several different organizations and groups of people that are affiliated with CCMI that are on the call today. So thank you very much for attending. And I think I will just turn it over to you, Kristy.
Great, thanks, Connie. So hi, everybody, and welcome to today's webinar. As Connie said, I'm Kristy Baxter, and I'd like to thank you for joining in today. So today I'll be talking to you about my master's thesis research, which is entitled Examining How Medical Practitioners Establish Therapeutic Alliance, Dynamic Systems Approach. Oh, sorry, one second. We just got click off. There we go. Okay. So I'd like to start off by telling the story of how this research came about and how CCMI became a partner on this project. So the story starts here in Kelowna, which is situated in the Oakland Valley, which is where I was born and grew up. So when I graduated from high school, I chose to stay local and attend UBC Okanagan. Interest in science and health, so I enrolled in the Human Kinetics undergrad program. During my fourth year, I did a research practicum under the supervision of Dr. Heather Gainforth, who is a leading expert in health behavior change. During this time, I was working on a research project, which was investigating the interactions between smoking cessation practitioners and clients, and this involved the coding of behaviors in real time. This project sparked my interest in dynamic systems and the patterns of behaviors within interactions, which I'll be unpacking more later on in this presentation. In 2016, I was preparing to graduate and I was interested in doing a master's, but I was still in the search for a topic that was interesting to me and was impactful. During that time, I found myself at the walk-in clinic, and I remember leaving my appointment feeling a bit dissatisfied with the interaction I had. Yes, the interaction got me to my end goal and I got an accurate diagnosis and a prescription, but the process of the interaction felt a bit lacking to me. And that's when I knew I wanted to research the process and patterns of doctors and patients interacting. So knowing we would need support for this project to be impactful and feasible, Heather reached out to both Connie Davis at CCMI and the Center for, the South Okanagan Similkameen Division of Family Practice. And once we began to discuss the project, there was shared interest and excitement from all involved, and quite quickly a partnership was formed. So now, after 2 years of collaboration and conducting the research, I'm excited to share with you today our findings. So let's dive right into the project. So patient-centered care is a necessary component to properly provide safe, high-quality care for people with chronic conditions. Patient-centered care focuses on the patient's values, needs, and desires, and is compassionate, empathetic, and responsive to patient needs. A notable aspect of patient-centered care is Therapeutic Alliance, which has been acknowledged as necessary for care to be patient-centered. According to Edward Borden, Therapeutic Alliance is comprised of 3 aspects: agreement on goals of the treatment, agreement on tasks needed to achieve the goals of the treatment, and the emotional bond that is formed between the practitioner and the patient. Therapeutic Alliance is important for effective care because it is related to therapeutic outcomes, such as patient adherence to medical advice, patient satisfaction with the care provided, and patient health outcomes. Therapeutic Alliance is currently measured using questionnaires, with the most commonly used being the Working Alliance Inventory, commonly referred to as the WAY, which is based on Borden's 3 aspects of Therapeutic Alliance. By using the WAY, the quality of Therapeutic Alliance can be assessed. However, a limitation to questionnaires is they do not allow for an understanding of the process through which therapeutic alliance is established between practitioners and their patients. Therefore, if we are to truly understand the process by which therapeutic alliance is established, we must begin to explore the reciprocal, dynamic, and real-time nature of verbal behaviors used by practitioners and patients within their clinical interactions. So unpacking that statement a little bit more. So currently the traditional way of exploring behaviors used within interactions involves coding for the presence or absence of behaviors used. For example, did the doctor provide the patient with advice at some point in their conversation? Yes or no? However, we know that conversations are more complex than this. They change over time, they involve a back and forth exchange between the people involved, and behaviors can vary in the frequency, duration, and sequence with which they are used. They are dynamic. Therefore, to truly understand the process, we must begin to explore the conversations in a manner beyond simply coding for the presence or absence of the behaviors that are being used. An observational method that holds promise for understanding how behaviors unfold in real time is state-space grids. State-space grids allow for the reciprocal, dynamic, and real-time nature of behaviors to be explored. Instead of simply exploring whether practitioners provide advice at some point in their interactions with their patients, state-space grids allow you to explore how often practitioners are providing advice, how much time practitioners are spending providing advice, or what the patient's most common response is when the practitioner provides them with advice. So what exactly is a state-space grid, and how does it do this where it measures the frequency, duration, and sequence of the behaviors being used? Well, here we have a simplified version of a state-space grid as an example, and we'll continue to use the example of a doctor having a conversation with a patient. So all potential behaviors for the practitioner are on the x-axis of the grid, and all potential behaviors for the patient are on the y-axis of the grid. Each cell within the grid represents a potential pairing of the behaviors of the practitioner and the patient. The practitioner-to-patient interaction is mapped within the total possible state space as a series of system locations, which are the dots that you see, which are co-defined by the behavior of both the practitioner and the patient at each given moment. So for example, this system location represents the practitioner listening while the patient disagrees. These system locations are connected sequentially in real time by the lines you see. So now the practitioner is using technique 3 while the patient listens. And the diameter of the system locations represents how long they spent in that state space, how long they use those behaviors. So in this, we see that the practitioner spent more time using technique 3 than technique 1. With the ability to explore the reciprocal, dynamic, and real-time nature of verbal behaviors used by practitioners and patients in clinical interactions, this methodology holds promise for understanding therapeutic alliance in a novel and innovative way. By using state-space grids, one could examine how different patterns of verbal behaviors may be linked to perceived therapeutic alliance between practitioners and their patients. This would not only allow us to advance our understanding of therapeutic alliance, but it may also allow for us to give evidence-based recommendations to practitioners on how to better establish therapeutic alliance. So therefore, the overarching purpose of this study was to use a dynamic systems approach to examine if and how practitioners and patients' real-time use of verbal behaviors is associated with the perception of therapeutic alliance between practitioners and a patient. As well, there were 3 sub-aims that aligned with our analyses, and these will be further illustrated and explored when we get to that part in the presentation. To accomplish these purposes, we used an integrated knowledge translation approach, which involves research users working together with researchers as active partners throughout the research process. IKT has the potential to enhance the relevance of the generated research to the research users, increase the research user understanding of the research process, and facilitate the uptake and application of the findings by the research users. As I mentioned previously, this project had 2 partner organizations that contributed throughout the research process: the South Okanagan Division of Family Practice and CCMI. For participants to be eligible in the study, they were required to be both 18 years of age or older and be a currently working medical practitioner from the South Okanagan Division of Family Practice. Convenience sampling was used to assist in recruiting as many practitioners to participate as possible, and practitioners were sent an email invitation from Dr. Tyler Murphy, who was a medical resident partner on this project, and as well, snowball sampling was used via word of mouth. In total, we were able to recruit 11 medical practitioners, of which 55% identified as men and 45% identified as women. 55% were less than or equal to 40 years of age, and 45% were 51 years of age or older. On average, practitioners have been practicing as a medical practitioner for 14 years, ranging from 1 to 34 years. Participants reported that they worked in their clinic, not including their out-of-clinic hours, on average 32 hours per week, and spent an average of 14 minutes per patient and had an average of 855 patients on their patient panel. 6 of the medical practitioners reported that they had received some form of goal-setting training at some point, and 7 reported they had received some form of patient-centered care training. Once recruited, practitioners completed an initial survey where they were asked to provide demographic and contact information. Practitioners were then scheduled for a session. The session involved a simulated medical consultation with a standardized patient over video conference. Both the practitioner and the patient were instructed to treat the session as if it were a typical doctor's appointment, to keep the session around 15 minutes in duration, and to conduct the session however they chose. A summary of the standardized patient's current concerns, background information, and medications was also provided. Each session was video recorded and transcribed verbatim. Following each session, the standardized patient and the practitioner completed the Working Alliance Inventory, which assessed the quality of therapeutic alliance that was experienced during their interaction. The practitioners were also asked to rate how representative the session was of a real-life appointment with the patient. Okay, so hopefully this works. This is an example video from our study featuring Virginia, who was our standardized patient who participated in the study, and Dr. Tyler Murphy, who was the medical resident partner on this project. So this is just to give you a little example of how those sessions looked.
Talking to the clinic, seeing if they have gone out. Yeah, and you're right, we're concerned about medication. I'm worried that people, they can become
Okay, so that's just to give you a little example of what those sessions looked like. And now we will move on to our analyses and results. So following the study procedures, analyses were completed in 3 steps. In step 1, the way scores were analyzed. In step 2, the coding framework was developed through transcript analysis. And in step 3, state-space grid analyses were performed using 3 different measures. So I'll provide a further description of each of these steps and their associated results now. So in step 1, 3 way scores were calculated for each of the 11 sessions. The practitioner way score, the patient way score, and the total way score. The practitioner way score is obtained by calculating the sum of the practitioner's ratings for the 36 way items, and a standardized patient way score is obtained by doing the same with their ratings. The total way score was obtained by calculating the sum of both the practitioner's way score and the patient's way score. Across the sessions, we found that there was variation in the highest and lowest rated sessions between the practitioner, patient, and the total way scores. Looking at the practitioner way scores, we see that session 8 was rated the highest, and session 1 was rated the lowest. In comparison, for the standardized patient scores, we see that they rated session 6 the highest and session 7 the lowest. And when we look at the total way scores, we see that session 6 is still rated the highest, and sessions 1, 7, and 10 are rated the lowest. In step 2, a coding manual is developed to reliably code for verbal behaviors within clinical interactions between practitioners and patients. The coding manual is developed by adapting the motivational interviewing skill code, abbreviated as the MISC, as the verbal behaviors of motivational interviewing closely align with patient-centered care and Therapeutic Alliance. The coding manual is further refined to assist in the coding of practitioners and patients. 2 researchers used this coding framework to independently code the transcripts. Narrator reliability was calculated throughout the process, discrepancies were discussed and resolved, and the coding framework was adapted to resolve any discrepancies. Upon the completion of transcript coding, the coding manual was finalized. Across all 11 transcripts, the 2 researchers coded 1,740 statements with an overall percent agreement of 69.62. In step 3, the association between verbal behaviors and Therapeutic Alliance was investigated using state space grids. The first step in creating state space grids is to use Noldus Observer XT, which is a software designed to allow for the continuous coding of multiple individuals from audio and video files. The developed coding manual, as well as all the final agreed codes for each transcript, were entered into Observer. While listening to the session video files, the timestamps for the start and the stop of each code for each of the practitioner and the standardized patient were entered. By doing this, the Observer software creates a duration-based stream of data for both the practitioner and the standardized patient. In other words, Observer allowed us to create a time-stamped list of verbal behaviors for both the practitioner and the standardized patient, so we can know what verbal behavior both people are using at any given moment during the session. As an example of what this looks like, we'll use this classroom setting. So you can see that on the left here, we have the time that the behavior is being performed at, the start time. In the middle here, we have the subject of who is performing that specific behavior. And on the right, we have the behavior that is being performed. From here, the timestamped list is then analyzed using Gridware. Gridware is a state space grid software that allows for the visualization and data manipulation of multivariate time series data. Each transcript produced 2 sets of timestamped data, one for the practitioner and another for the standardized patient. These data represent every verbal behavior for both the practitioner and the standardized patient during the interactions. Gridware was used to create X and Y coordinate state space grids representing each session by integrating these 2 sets of timestamped data. So this got us to 1 state space grid for each session, resulting in a total of 11 grids. These grids essentially provide us a picture of the data from each session. To give a more in-depth look and understanding of the created state space grids, I'm going to compare 2 of the sessions that were rated highest and lowest by the standardized patient, session 6 and session 7. So on the left, we have session 6, which was the highest rated by the standardized patient, and on the right, we have session 7, which was the lowest rated by the standardized patient. In both grids, we see how the practitioner and the standardized patient sessions have unfolded over time. On each grid, all possible practitioner statements are represented along the x-axis, and all possible standardized patient statements are represented along the y-axis, similar to the example I showed earlier. Each data point within a specific cell on the grid represents a code-defined behavior for both the practitioner and the standardized patient, and each line on the grid represents a transition from one code-defined behavior to the next. As an example, let's consider the code LAS, which is along both the far right column and the top row. LAS stands for listening, and within these sessions, either the practitioner or the patient is listening, while the other performs a verbal behavior. When comparing between these 2 sessions, state space grids allow us to see that in session 6, the practitioner and patient transition between who is listening and who is talking less often than in session 7, where the thick, dark lines indicate far more transitions. We can also see a greater frequency of questions asked by the practitioner in session 7, indicated by the dark areas of the codes QUO and QUC. From even an initial observational examination, state space grids begin to highlight the differences across sessions in their frequency, duration, and sequence of behaviors being used. By using state space grid analyses, these differences can be investigated even further. 3 types of state space grid analyses were performed to both compare state space grids between practitioners of varying Therapeutic Alliance ratings, and as well examine behavior patterns within the practitioner and standardized patient sessions. These analyses included measures of attractor states, which looked at the most commonly used verbal behaviors by the practitioner. So think of these as like your favorite pair of socks, behaviors that are being used quite often. Variability measures, which examine how often or quickly the practitioner and the patient change the verbal behaviors they're using. This is like the turtle and the hare story, a comparison of quickness. And just like in the story, we may see that quicker may not always be better. And lastly, we have conditional pairing, which looks at the most common patient responses to practitioner verbal behaviors. All of these analyses were compared with both the practitioner and patient WAIS scores to explore how the frequency, duration, and sequence of behaviors used was associated with the quality of Therapeutic Alliance. The first state space grid analysis investigated which verbal behaviors were most used by the practitioners by examining attractor states, those well-used behaviors. 4 behaviors were commonly used across the 11 sessions: giving information, providing advice with permission, asking closed questions, and providing simple reflections. These behaviors, along with other behaviors that are closely aligned with motivational interviewing, were correlated with both practitioner and patient WAIS scores to examine how the frequency of behaviors used by the practitioner affected perceived therapeutic alliance. Presented here are two different practitioner behaviors correlated with both the practitioner WAIS scores, which you see in the orange, and the patient WAIS scores, which are in the blue. A non-significant negative relationship was seen for the frequency of practitioner questions asked in both the practitioner and patient WAIS scores. And a non-significant negative relationship was also seen for the frequency of practitioner advice statements and mainly the patient WAIS scores. Here are two other behaviors that were correlated with therapeutic alliance. The frequency of practitioner support statements was weakly associated with practitioner WAIS scores. However, a significant positive relationship was seen with the patient WAIS scores. And lastly, the frequency of practitioner giving information statements was weakly associated with patient WAIS scores. However, a significant negative relationship was seen with the practitioner WAIS scores. These results highlight the importance in considering the frequency with which practitioners use certain behaviors rather than if they are simply used or not. State-space grids also allowed us to examine the variability across sessions in terms of range of cells used, total transitions, and average duration per visit. Using these three measures, we learned two things about these sessions. First, there are similar behaviors used by the practitioner and patient across the 11 sessions, indicated by the minimal variability in the range of cells used within the grid across sessions. And second, the sessions differed in the quickness of the conversation, shown both in how often they switched between behaviors, total transitions, and in how long each behavior was used, average duration per visit. Both the number of transitions and the average duration per visit were correlated with the WAIS scores. A non-significant negative relationship was seen for the number of transitions within a session in both the practitioner and patient WAIS scores. And a non-significant positive relationship was seen for the average duration per visit within each session in both the practitioner and patient WAIS scores. These findings highlight the value in considering the duration with which practitioners spend on each behavior and how quickly they transition between these behaviors. When using state-space grids to examine the conditional pairings, there are a few common trends that emerged. The only conditional pairing that emerged across all sessions was the patient responding with giving information when the practitioner asked a closed question. Therefore, only this conditional pairing was correlated with WAIS scores. The number of times the patient responded with giving information to a closed question asked by the practitioner was weakly associated with practitioner WAIS scores. However, a significant negative relationship was seen with the patient WAIS scores. These findings highlight the value in considering the sequence of behaviors used between practitioners and their patients, rather than simply their individual use of behaviors. So the study provides initial insight into how therapeutic alliance is established between practitioners and their patients in real time, and highlights the importance of using a dynamic systems approach to understand how therapeutic alliance is established between practitioners and their patients. By using state-space grids, we are provided with a novel and more nuanced understanding of how therapeutic alliance may be established in real-world interactions between practitioners and their patients. Previous methods have only looked at the presence or absence of practitioners and patients' verbal behaviors and have not linked these behaviors to therapeutic alliance. By simply looking at the presence or absence of verbal behaviors in these interactions, one could conclude that there are few differences in the way in which practitioners and patients establish therapeutic alliance. However, our state-space grid analyses reveal potentially important differences in the frequency, duration, and sequence of behaviors used across sessions and how these differences may influence therapeutic alliance. To illustrate the importance of using state-space grids to consider the frequency, duration, and sequence of behaviors used, session 6, which was the highest rated, and session 7, which was the lowest rated, can be compared. While the study is exploratory in nature and results should be interpreted with caution, these comparisons may provide further insight into how valuable state-space grid analyses are to better understanding therapeutic alliance. So session 6 was the highest rated session by the standardized patient and best highlights the positive trends of behaviors associated with therapeutic alliance. In contrast, session 7, which was the lowest rated session by the standardized patient, highlights the more negative trends of behaviors associated with therapeutic alliance. The practitioner of session 7 asked the highest frequency of questions, whereas the practitioner in session 6 also asked questions, but did so less frequently. Session 7 had both a higher number of transitions and a lower average duration per behavior when compared to session 6, indicative of a faster paced conversation. And while the practitioner in session 6 spent enough time providing supportive statements to make it one of their top 5 behaviors, The practitioner in session 7 was allocating enough time to providing advice to make both providing advice with and without permission 2 of their top 5 behaviors. These few examples illustrate the importance of using a dynamic systems approach to understand the process with which Therapeutic Alliance is established. It is not enough to simply know the presence or absence of behaviors used. It is necessary to understand and explore the frequency, duration, and sequence with which these behaviors are being used. Otherwise, we may miss these important differences that may be hindering or fostering Therapeutic Alliance. And if you remember nothing else from this presentation, here are a few practical implications closely aligned with those provided by motivational interviewing that practitioners can consider in their practice. Practitioners should be cautioned about falling into the assessment and expert trap by asking several questions and giving ample information or advice. Rather, practitioners should consider spending more time creating a relational bond with the patient by providing support statements. Overall, it seems important for practitioners to consider how often, for how long, and in what sequence they use behaviors, similar to when following a recipe. And lastly, this research cannot state the optimal dose of behaviors to establish Therapeutic Alliance, but it seems that dose does matter. In conclusion, this study was the first to use dynamic systems methodology to examine how verbal behaviors are used within clinical interactions between practitioners and their patients. It provides novel insight into how Therapeutic Alliance is established between practitioners and their patients in real time, highlighting the importance of using a dynamic systems approach to understand the frequency, duration, and sequence of behaviors used between practitioners and their patients. I'd like to end by thanking my co-authors on this project, as well as our partners who have greatly enhanced the quality of this research. I'd also like to thank CIHR for funding this project. And with that, I'll close by thanking you all again for taking the time to be here today. And it has been a privilege to share this work with you. And I believe that we have time for questions, if that works.
Yes, we have time for questions, Kristy. Thank you so much. So I'm very curious, and I'll get started with questions while perhaps some other people will formulate their questions while we're talking. Your original impetus for this was an interaction that wasn't the best that you had with a healthcare professional. And so I'm curious if your research findings match your recollection of what maybe didn't go so well in that interaction that prompted the whole study.
Yeah, I would say that it does mirror what that interaction felt like. It was one of those interactions where you feel like you're the absorber and the person you're talking to is the expert. And yeah, I felt like when I left, I wasn't any more knowledgeable of what was going on, but I just knew that I had a diagnosis and I had a prescription and I was good to go, but I didn't know why that was or where those thoughts or choices came from. And I feel like I wasn't, I didn't have an active role in that interaction. And yeah, I think that definitely mirrors what we saw in our practical implications and in our correlations with the WAIS scores. Just trying to get patients more involved and more active participants in that conversation, and as well giving them those supportive statements that make them feel more valued and more human and making it more patient-centered.
Yeah, I think that's super interesting because, of course, I come from a background with motivational interviewing, and there's been quite a bit of conversation lately about the contribution of the relational components of an interaction with the technical components. And I think what you found really underscores that also.
Yeah, definitely.
Mm-hmm. Mm-hmm. And so the way the relationship, if you were to think about how does relationship show up in the state-space grid, what were the ways that you kind of were able to capture that?
Yeah, I think some of the main ways were definitely the supportive statements, I would say was a big code for that. And that often showed up when some of the doctors would just say things like, what you're going through is completely normal. I totally understand where you're at, and just making them feel, human and making them feel heard and understood. And as well, I think it showed up a lot in the conversations where there was more time spent having the standardized patient have a chance to respond rather than that more quick back and forth exchange. I feel like in those conversations, there wasn't enough time for the standardized patient to delve into what they were trying to get to in their point. And yeah, I just feel like the doctors that were able to get the standardized patient to speak a bit longer, those were moments where they were really thinking and getting into, why do I feel this way? What am I needing? And actually really deeply consider what their thoughts were on their concerns.
Mm-hmm. So that's really interesting too, because when we're teaching motivational interviewing, one of the things we often help people to realize is how powerful, what we call partnership statements are. So just the kind of statements you were talking about, I'm here to support you, whatever. And also autonomy supportive statements, the times when you say, it's up to you, the ultimate choice is yours. I have some expertise, you have expertise. I mean, all those kinds of statements, autonomy, support, and partnership.
Yeah.
There is a question in the chat box about selecting the patient. So if you want to talk a little bit more about why you used a standardized patient and what that meant, because there's some questions about cultural differences, which might be interesting. Right. Just what your thoughts might be.
Yeah. So in terms of this study and it being a proof of concept, something where we were trying to see if state-space grids would work in this setting and in this type of research, the standardized patient allowed us to do that best and to see these differences in WAY scores in a way that didn't have as many confounding variables. So we didn't have the ability in the study to account for cultural differences that may come up in patients. As well, there was lots of other differences that definitely could be more investigated using a variety of patients. But yeah, just in terms of this being a proof of concept and a first study and for feasibility sake, the standardized patient was the best choice in this scenario, but it would be very interesting to do future research with a bigger variety of patients and having more of that real world feel for patients.
So there's ample room for other researchers out there to explore this more.
Yeah, I would say that.
Great, that's excellent. So I guess, when you think about future research, what would be the things you're most curious about and you would hope that maybe yourself or others would really be trying to understand?
Right. Well, I thought it would be interesting to I can't exactly remember the term, but do a recall with the practitioners or the standardized patient and go back through these video files with them and ask them questions about why they said what they said or why they or how they felt in a certain moment when someone else said something, and maybe how that comment or that statement or that piece of advice made them choose the score that they did on the Working Alliance inventory. I think it would be very interesting to get that qualitative piece of how and why these conversations make people feel the way they do and why they choose to give the ratings that they do on the Working Alliance inventory. Because yeah, we don't have that piece. We can make thoughts or guesses at that, but yeah, it'd be very interesting to be able to go back and interview the participants that were involved.
Yeah, excellent. Just want to encourage people to go ahead and chat in questions if you have them. Of course, I have many questions because I was so interested in this topic to begin with, but yeah. So I guess I'm also curious about the physicians, and so what kind of a debrief or presentation were you able to do, or are you going to be able to do for the South Okanagan-Similkameen Division of Family Practice that was so supportive of the project? What's the next step for them?
Yeah, so I've been in contact with Suzanne at the South Okanagan, but there hasn't been a date set for any of these things yet. I do know that Dr. Tyler Murphy, the medical resident on this project, we were just chatting and he's very interested to hear the findings and results. So we were hoping to meet in the next couple months and go from there. But yeah, there hasn't been any firm transfer of findings with the South Okanagan quite yet, but we have been in contact to try and figure that out.
That's excellent. And so what are your plans to spread what you learned in this project?
Yeah, there's so many options. Like this is a super exciting opportunity right now. I definitely would love to do a presentation or a follow-up with the South Okanagan as well. We do plan to publish this research. We're not exactly sure in which journal article yet, but that is a plan. And yeah, I think any sort of community outreach would be super interesting. And so if Connie, if you hear of anything or have any ideas, you can let me know. But yeah, there's no firm plans set right now. It does get a bit more complex now that I'm no longer a student and have been working. But this research still is very valuable to me, and I would love to get it out there in any way that we can.
Yeah, I think it is important to spread what you learned. And so I think, CCMI would love the opportunity to be able to just, when you're published, and we can share the information, because it's great evidence to have to back up some of the things that we encourage people to learn when we're doing skill-based workshops. And I will let you know and keep watching for the motivational interviewing group. Usually has a research conference every 3 or 4 years, and they're about due to do one again. So I hope there's going to be another research conference. There are many researchers there, but I think you'll be very interested in what you did, what you've learned.
That's great. Thank you.
Yeah, that's awesome. So other questions from folks who want to unmute or have some questions or comments? And Virginia, I'd also invite you as the standardized patient, if there's comments or thoughts you have too.
Yeah, thanks, Connie. Well, I was just, Kristy, when you were posing the possibility of doing kind of a recall or like follow-up, that sounds super interesting to me. Just because like going a little bit deeper into the understanding of how and why certain interactions feel good to a patient and some styles of interaction don't. I think that can be super valuable. So yeah, if you ever want to do that, let me know.
Sounds good.
Yeah, and it's just really interesting to see the full picture of the research from start to finish, having been involved in it, early on, and to see the practical findings from it, really in many ways matching what the experience was of acting as the standardized patient. So some of the findings seem pretty on based on where I sat in the project.
Great to hear. Thank you, Virginia.
And I do want to make sure you see the lovely comment from in the chat box there of thanking you for this important work. It's really true.
Yeah, I'm looking at it.
Kristy, I wonder if it's possible to explain a little bit what the standardized patient scenario was that Virginia played, because I think people might be interested in how that evolved through the partnership, about what the topic and how that happened.
Yeah, definitely. So we went through a couple variations of what we thought the standardized patient would look like and who they would play. Originally, we had thought about doing diabetes or frail elderly, but just based on Virginia and her current age, frail elderly didn't well match what she would look like on video. So we went with a scenario that was a bit more realistic for who Virginia is. So we ended up going with a woman who had recently suffered from a car accident, and then from that had chronic insomnia, pain, and anxiety. And so in this scenario, she often spoke of wanting to reduce her medications, but also having a hard time with that because she was experiencing so much pain. And oftentimes they did get into more beyond just the medical sort of pieces, talking about her daughter and her social life and getting out of the house and being afraid to drive. And yeah, also most of the doctors touched on lots of different resources that are available, whether that was a pain clinic or different websites or different exercises that could be used. So yeah, that was kind of how the standardized patient role came about, and Virginia did a very excellent job. And it was, yeah, all the doctors responded in the post questionnaire that they agreed that it was very representative of a real life appointment with the patients. That was super awesome to see.
And I think it's really important that it was an issue that had so many psychosocial and like a behavioral health and a primary care component to it. And also thinking about pain, medication, and chronic pain, because those are some things that are very current topics for physicians, and that we know that so many behavioral health issues show up in primary care. And so I think it's really a wise choice. Excellent.
Kristy, Virginia here. When you were speaking, I thought about the pre-step before moving to video, where initially we had talked about doing the sessions by telephone, hence me role playing a 75-year-old real elderly, patient would have been more workable. And then we made the switch to video. So yeah, anything that you want to say about that piece of it, the phone to video?
Yeah, right. So yeah, we did originally plan to do this over phone, as other studies I've been involved with that are similar to this have used phone, but more in like a mentorship sort of setting. And so then after bringing this project to Dr. Tyler Murphy and Suzanne and Connie and Virginia, we discussed how it would be more realistic and it would be of value to doctors to be able to do a video conferencing appointment, since rural health is becoming a bigger thing, and being able to reach out to people in rural areas via video conference. And so, yeah, once we talked about that with all the partners, we realized that that would be a huge value. And so after talking to IT and tech on campus here, we discovered that there's this program called Video, which worked super well for the study. And Virginia and the doctors would just sign in, and I would start the recording after giving the instructions. And yeah, they would do their session over the laptop, over video, and it worked super well. So yeah, when we decided to make that change, we realized that Virginia's appearance wouldn't match frail elderly anymore. So we
I had to be younger.
Yeah.
Excellent. Any other questions from the participants? Well, again, it looks like maybe we are at the end of the presentation, but I just want to thank you so much, Kristy, for being willing to share this important research with us. And I'm looking forward to hearing more about how your efforts at publication and sharing your study in wider realms is managed, how you can get the word out. So important stuff for everybody to know about. So thanks and best wishes.
Oh, thank you so much, Connie. It's been such a pleasure to be able to share this through this webinar. This is a great opportunity. Thank you so much for providing it.
Okay. All right, well, thank you everyone for coming. And this is the final scheduled webinar for the Brief Action Plan and Community Practice. It was something we had been doing on a periodic interval, and we found that it wasn't as helpful to the community as we thought. So we're going to take a different tactic on sharing information with that particular community practice. But and we want to thank our BAP members and our trainers for being here for this webinar. So thank you so much.
Thank you, everyone.
Thanks, everybody.